Okay? How many of you do non-con plus CTA? Okay, that's kind of the established practice, it looks like. How many of you use other advanced imaging modalities such as perfusion? CT perfusion? About half maybe. And then how many of you are using MRI to screen and triage stroke? Interesting. Okay, so there are a few of you who are using that. We don't have a MR scanner. It's kind of logistically tough for us to do our best care for patients in a timely fashion, so a lot of what we do is CT. So the message again, CT plus stent retriever, but we really don't know how to best use CT angiography to select patients for benefit. So in the talk today, really what I'm going to march through is essentially the following lineup. First, we'll talk briefly about stroke in the US, give you some background demographics. We'll talk about some basic physiology and concepts in development of stroke, the current clinical and imaging assessment tools that were used in these trials, and how the AIS, or acute ischemic stroke management, has changed over the past 2 decades. And then we'll touch on some of the controversies that are currently going on. So first, if you look at this map, there's a lot of purple kind of in the southeast. If you're practicing in the southeast, I think you see a lot of stroke. It looks like in the Midwest as well. We see a fair bit. We have a busy practice, but this is a growing problem. The rate of stroke is actually increasing around the country. Right now, at this point, there's about 800,000 new or recurrent strokes. About 75% are new in a year, 25% recurrent. Annually in the US, it's a third leading cause of death. There's probably going to be about 1.2 million strokes per year by projections in 2025. So the number of patients who die with stroke is going to increase as the disease becomes more prevalent. Deaths are more frequent in females than males, roughly a 60-40 split. And if you kind of break down all of the demographics, there's currently, in 2013, I believe, there's a stroke about every 40 seconds, and someone dies from a stroke every 4 minutes. So certainly a very costly disease, and both on a personal standpoint and a cost standpoint. One of the things to understand about mortality in stroke is that the mortality of the disease depends upon where the thrombus is. We tend to think of stroke as one big piece of pie, but in actuality, there's a number of different types of stroke. The most common strokes that we think about are these in the anterior circulation, the MCA and the terminal ICA. Remember, the basilar artery infarcts have the highest rate of mortality among different types of strokes, and then kind of followed by the carotid terminus, and then finally by the MCA bifurcation or more distal infarcts. There's a number of other clinical variables that impact prognosis. It's a very complex disease. We talk a lot about time to treatment and door to needle times and door to cath now. The stroke severity at the onset modulates the outcome. The age of the patient, the race of the patient, the weight of the patient, their blood pressure, their presentation with hyperglycemia actually modulates their ultimate outcome. And then a number of comorbidities like atrial fibrillation, cancer, coronary artery disease, dementia, diabetes, renal insufficiency. So there are a number of different clinical variables that impact care as well. From a broad standpoint, there's really 3 types of acute ischemic stroke, and the one that gathers the most interest and kind of the most sexy from the field of neuroradiology are these large vessel strokes. Again, the LVO, large vessel occlusion, that's about 1/3 of infarcts. Why do they gather so much attention? Because these are the ones that really have the worst outcome. About half of strokes are actually mild strokes. They don't typically have a large vessel occlusion. They may have a small infarct volume. The outcomes are good. Lacunar infarcts, as you saw in the last lecture, have a smaller volume. The small vessel infarcts at least have a smaller volume, and so they tend to have, it's a little bit of game of battleship, so it depends on if you hit the PT boat or the long boat. But the general idea at present is the treatment goal is really to shift the current disease of large vessel occlusion, major stroke, to that of mild stroke. And that's the whole idea of endovascular therapy, IV TPA. Can we make the profile of patients who have large strokes match more of the profile and outcome of patients who have mild strokes? A lot of attention in the literature on kind of the physiology of stroke, and you've all heard of the concept of a penumbra. This is now widely circulated picture from one of Gil Gonzalez's paper showing the concept of a penumbra where you have in this case, an MCA clot in black in the right cerebral circulation, and there's a core infarct. This is dead tissue that has no chance of recovery, surrounded by a variable size penumbra. The penumbra is ischemic, but not completely dead tissue, yet it's sustained by collaterals. And over time, this kind of core may change in size, depending on the degree of collateralization, depending on the degree of time. But take a step back. Where did this concept come from, the concept of penumbra? Well, this is now a 30 years old paper, is based on the temporary and sometimes permanent occlusion of the MCA in rhesus monkeys, kind of showing the impact of ischemia and the duration of ischemia on the ultimate infarction or death of tissue. So you can see that with severe reduction in blood flow, cells die within moments, whereas with larger or longer degrees of time, with cerebral blood flow that is not as dramatically reduced, you can sustain a longer period of time without infarcting tissue. So this is kind of the penumbra concept. So if I were to look at this, I take an area of tissue that's at risk of infarction at the initial onset. There's no cell death at all. There's a clot sitting in this patient's left MCA. This tissue is at risk of infarct, but it takes some time over which the collaterals are currently sustaining the tissue, and with collaterals and with time, ultimately that penumbra runs the risk of growing into a complete infarct, and you'd like to interrupt that process. Now, this is a widely publicized number, widely publicized paper by Jeff Saver. The concept of time is brain, and in this paper, he described how the typical patient loses around 2 million neurons per minute. I mean, this is a fair number of neurons, and one way of looking at this is compared with the normal neuronal loss as you age. The ischemic brain ages about 3.6 years per hour. So you're very rapidly aging once you have a stroke. But one of the things that's kind of been more recently shown is, time as brain is not just a matter of linear time from onset to treatment. The core growth is not linear, it's actually logarithmic. So the evolution of the ischemic lesion in rats, and this is a kind of a rat model where they occluded the MCA, showing you on the y-axis the lesion volume, and on the x-axis the time post-occlusion. You can see that the number of neurons is not X number of neurons per minute. It actually, that rate changes depending on how far you are from the ictus. So it's probably a logarithmic curve, at least in animal models, and there's a fair bit of variability between different animals, and so the rate can change. So the concept is time is brain, but we're not really sure at which rate the curve is changing and how to identify patients at best risk of salvage. What are the clinical and imaging tools that were used in the 5 recent trials? You can see here the CT perfusion. There's also the clinical tools kind of getting people to the hospital. From a clinical trial standpoint, there are really 3 metrics that were used. One is time to treatment. The other one is severity of stroke, how severe is this stroke clinically. And the other one is the outcome. So this is the modified Rankin scale is used for this. So how severe is a stroke? Your clinicians will use this number if you're in a primary stroke center. This is the NIH stroke scale. This ranges from 0 to very large numbers, 23 or higher. And in these cases, mild strokes are defined by low numbers, and 20 or higher is a higher number. And you can see this is kind of a fast metrics on the left. That column is showing you the kind of things that a clinician is examining the patient, their level of consciousness, their visual fields, their eye functions, their ability to move against gravity, et cetera. It's a very fast exam, it's reproducible, and it's used for patient selection right now. Now, why is that? If I look at all comers of patients who have stroke and I divide them into their NIH stroke scale and I look at their outcome, divided into those that have excellent outcomes, meaning no deficits, and those that are dead, the NIH stroke scale at presentation has a very significant impact on that. So patients with severe strokes, 17 or higher, tend to do very poorly in aggregate in comparison with patients with lower strokes. So this is kind of the clinical picture and the clinical assessment. Now the trials also use this modified Rankin scale. This is a way of measuring disability in patients who've had a stroke. This is usually done at 3 months out. It's a scale from 0 to 6. You don't want 6 very bad. 0 is no symptoms at all, and then after that it's really defined by disability and the degree of disability and whether or not you're functionally incapacitated in terms of your daily, day-to-day life. Most trials use the kind of scale on the bottom, so they call a success anywhere when the modified Rankin scale is less than 3, and a failure when it's greater 3 or greater. And one way of looking at this is, are you alive? If not, then that's a 6. If you are you independent? Then you're at least a 3. And if you're independent, do you have symptoms? So a good outcome is from 0 to 2. A poor outcome is essentially from 3 to 6 in these modified Rankin scales. Now, here is the first trial, and you'll see a lot of plots like this in these papers. This is what they look like, dividing intervention and control arms by their modified Rankin scale, plotting the percent of patients along each axis. And you can see that very clearly, kind of visually, again, using the severe to on the 6 scale and then 0 on the left, you can see a dramatic shift towards good outcomes with these trials. Now, what were the imaging tools used for these trials? There were a number of different imaging tools. All of them use CTA, unlike prior trials in the past. So in this case, CT or MRI was used in every case. Why? Primarily for the exclusion of hemorrhage, also for the identification of core infarct, which is done for trials using the aspects score, which we'll talk about a little bit. CTA was used, or MRA, in a subset of cases for identification of the site of large vessel occlusion and measuring the length of the clot at some points. Characterization of core and penumbra was done in a few trials, not all of them. Detection of collateral arterial supply using new techniques was used in a few. And finally, almost all of these use some measurement of reperfusion in cases that underwent intervention. So these are defined by modified Ticky scales. And I'll show you those in a minute too. So non-contrast CT, the primary role is to exclude hemorrhage in patients presenting with acute infarct. Here, typical basal ganglia hemorrhage. Patient should not get TPA, goes on to management of their hypertensive or other cause hemorrhage. What do we see in stroke? You've seen these hyperdense vessels, loss of gray-white. When the gray matter is highly vascular and tends to be just a little bit more dense, and so the loss of gray-white reflects shifts in water, and so you have blurring of the gray-white boundaries, often involving the cerebral surface, sometimes involving the insula, the lentiform nucleus sign, kind of a classic sign for MCA infarct. As the brain becomes swollen, the sulci become effaced. All of these different features are features of stroke that you're familiar with. The insular ribbon here, a subtle case of loss of gray-white and subtle swelling of the gyrus right around the hand knob. Low density, at this point, this is a core infarct. The cat is out of the barn. You're not going to get this tissue back at any point. So non-contrast CT, very useful to identify hemorrhagic stroke, but when we see hyperdense MCA, that's great, but the sensitivity is actually fairly low. It also has limited sensitivity for ischemia. Even seeing ischemia, we don't really see. And then if you or I or anyone in the room were to sit down and gauge these, it has very low inter-rater reliability. So hence the introduction of the aspect score by a group in Canada, used For MCA infarction in particular, it's a 10-point scale, 0 to 10. The higher the number, the smaller the core of the infarct. Here you're looking primarily at swelling and loss of gray-white involved territories. Involves really looking at two separate levels in the brain, one at the level of the basal ganglia, and one what they call the supraganglionic, or above the level of the basal ganglia. It doesn't mean you just look at two images. These are the structures. You scroll through those different levels and you decide, is the anterior MCA involved, the M1, M2, M3, and then around the basal ganglia is the caudate, the lentiform, insula, and internal capsule involved. And for each of these involved areas, you subtract a point. Now here's kind of the supraganglionic M4, M5, M6. Now, oops, getting lost here. So why is this important? So if you do large numbers of patients, an aspect score of 7 or less predicts a worse functional outcome, as well as symptomatic hemorrhage. So the lower the aspect score, the larger the core of the infarct in general, and the worse the outcome. So it gives us a way of standardizing the estimate for the core of the infarct based on a non-contrast CT. Now, what is the primary role of CTA? Of course, it's to localize thrombus. This turns out to be a major difference from the new trials, from the last trials. Most of the last trials did not use CTA, and therefore you were never even sure if a thrombus was actually present. So in this case, a CTA was performed in all of these trials, and I would say that a CTA in our practice actually has a number of roles, not only to identify the thrombus, but our interventionalists use it for endovascular planning. They want to know, is the arch anatomy normal? Am I going to be able to get through the carotid bifurcation? Are the cervical vessels too tortuous to navigate? And this sort of thing. Now, the best estimate of core volume is, of course, diffusion. And those of you who have an MR in the ER, we're very jealous. We would like to have this. Diffusion is certainly the best current method of measuring which tissue has irrecoverable ischemic injury. And this was measured through a number of clinical trials. Diffuse, MGH has their own kind of level data set. Epithet is another trial. The number varied a little bit. I think most people are using 70 as kind of a dichotomy for which patients do poorly and which do better after thrombolysis, and this is just kind of IV TPA. This is one paper by Albert Yu showing you the core infarct volume on the x-axis. So towards the 0 point, these are small core infarcts. Towards the upper end of the scale, these are larger core infarct volumes. And then how well patients do in each of these, this is just kind of the number of patients along the y-axis. Obviously, the smaller the core infarct, the better patients do. The larger the core infarct, the worse patients do. So you can define, to some extent, a threshold greater than 70, less than 70. If it's greater than 70 or greater than 100 by some people, patients tend to do poor overall. The diffusion, if you score it with the aspect system that we just described, you can also predict the risk of hemorrhagic conversion. So when the aspect score is particularly low, as measured using diffusion with a large core volume, the likelihood of symptomatic hemorrhage with TPA is actually very high, or higher than normal. Now, those of us who use CTP, if I were standing here 7 years ago, this was the dictum that we do CT perfusion. We're measuring mean transit time, cerebral blood flow, and cerebral blood volume. And when we see a prolongation in mean transit time, this large blue area in the left map that tells you that something is wrong, maybe either just reflects stenosis or a penumbra or a core, depending on the values of the cerebral blood flow and the cerebral blood volume. Usually if you just have a stenosis and you use delay correction in your software, then the cerebral blood flow and blood volume should be normal. The penumbra is when your cerebral blood flow is down. You don't have an infarct until your cerebral blood volume goes down as well. Now, the last several years has seen this be the subject of considerable debate. CT perfusion ends up being a very, very noisy modality. It's somewhat subjective. It really depends on who's processing it. Each of the vendors has their own processing algorithm, and there were several papers that showed that depending on which software algorithm I'm using to process it, I'll get different results as to the volume of the core infarct and the penumbra, which makes it very tough if you're going to use a magic number like 70 to use in practice. It probably overestimates the volume of the core infarct. There's some other physical limitations in CT perfusion. Usually brain, unless you have a new 256 detector scanner, the coverage is limited to about 8 centimeters or less. Patients tend to move during these scans. And there's, of course, a number of widely publicized articles showing radiation dose concerns in patients with loss of hair and skin burns from CT perfusion. And not only that, but even if you're able to acquire the data, you have to be able to process it very rapidly. These are being used to make decisions in real time. And then more recently, there's actually a commercial market that's evolving around how to do this. 2 of the trials use the so-called RAPID software, which is dumps images like this out. This is a company, a Schema View. I have no financial relationship with them whatsoever. But it dumps out maps of cerebral blood flow, cerebral blood volume, using their own kind of proprietary algorithms, but it dumps it out in a very systematic fashion. The data goes right from the scanner to the box processes this, spits these out. Actually, people on the stroke team can look at their cell phone, and it kind of goes right to their cell phone and answers these questions. So the Stanford group uses this, and they're using it for some of their treatment decisions. Our group doesn't use it at all for treatment decisions. We still collect this data. Why? It's kind of nice to be able to use for research purposes. And then we do use it somewhat to lay crepe for patients. So for example, if a patient is in the window eligible for endovascular therapy, they have a very malignant collateral profile, very malignant perfusion. So sometimes the angiographer will say, you know what, we're going to do this, we're going to do everything we can, but this is not likely to be a good outcome. And then sometimes we have used it as well in patients who don't meet criteria. So patients who are outside of the window for thrombolysis or endovascular therapy, they're outside of 6 hours, they don't meet traditional criteria, they have a beautiful perfusion pattern. You can use that to try to argue that maybe you should go in, try to do your best for the patient.